If you take a blood pressure pill every single morning, stay with me for the next few minutes, not because something is wrong with you, but because there is a very good chance that nobody, not your doctor, not your pharmacist, not anyone, has ever sat down and walked you through what that pill is actually doing inside your body, and more importantly, what it might be doing that has nothing to do with your blood pressure at all. You have probably already seen videos on this topic, and most of them give you the same short list and move on, but what I want to do today is go deeper, because the part that gets left out is usually the part that affects how you feel when you wake up in the morning, how steady you are on your feet, and how much energy you actually have to get through your day. Here's what we are covering today. 11 things that people taking Amlodipine, Losartan, or Lisinopril are rarely, if ever, told. And by the time we are done, you will have a clear picture of how each of these medications actually works, what to watch out for, and a set of specific questions ready to bring to your next doctor's appointment. Stick with me through all 11 because number 4 is the one that concerns me most. It shows up with no warning, no symptoms, and it is completely preventable with one simple blood test. And number 6 involves a blood pressure reading that looks perfect on paper, but could be putting you at serious risk every time you stand up. Before we get into the list, I want to give you one idea to hold on to because it will make everything else click into place, and I call it the numbers trap. And here is how it works. Your doctor prescribed your medication based on established clinical guidelines. Those guidelines were built on real research, but here is something most patients are never told. Much of that foundational research was done on people who were younger, healthier, and not managing several other conditions at the same time. And by the time you are in your late 60s or 70s, your body is processing medication very differently than it did 20 years ago. Your kidneys filter more slowly. Your liver clears drugs at a different rate. Your blood vessels respond differently to the same dose that worked fine when you were in your late 50s. And here is the second half of the trap. When side effects show up, fatigue, dizziness, swollen feet, mental fog, a cough that will not quit, the easiest explanation in the room is that is just aging, and because the blood pressure number on the chart looks fine, nobody looks further. That is the numbers trap. The chart looks good, so everyone assumes you are fine and no one asks how you actually feel. So keep that in the back of your mind as we go through this. Dot number 1 is about 3 medications, 3 completely different mechanisms, and why knowing the difference actually matters. And Carol Patterson is 67 years old, a retired kindergarten teacher from Louisville, Kentucky, who has been taking a blood pressure pill every morning for 5 years. And when her granddaughter asked her how it works, Carol paused and realized she had absolutely no idea. She had never been told. She had just been told to take it. And Carol is not unusual because the vast majority of patients on blood pressure medication have never had the mechanism explained to them. And it matters more than most people realize. So here is the simple version. Amlodipine is a calcium channel blocker that works by relaxing the smooth muscle in the walls of your arteries, allowing those vessels to widen so blood can pass through with less force. Losartan is an ARB, an angiotensin receptor blocker, and your body produces a hormone that signals your blood vessels to tighten, and Losartan blocks the receptor that receives that signal so the signal gets sent but nothing happens on the other end. And Lisinopril is an ACE inhibitor that works one step earlier by preventing your body from producing that blood vessel tightening hormone in the first place. Same goal, but 3 completely different pathways. And each pathway carries its own set of side effects, its own list of drug interactions, and its own set of risks that grow more important as you get older. So here is your first question to bring to your doctor. Why was this specific class of medication chosen for me and not one of the other 2? And the answer should be specific to you, your kidney function, your history, your other medications, and if the answer is vague or generic, that conversation is worth continuing. Dot number 2 is about swollen ankles that nobody takes seriously until they should have, and Frank DeLuca is 70, a retired plumber from Pittsburgh whose ankles started swelling about 6 months after he began Amlodipine. And by the end of the day, his feet were spilling over the edges of his shoes, and his doctor told him it was a common side effect, harmless, just elevate your legs, and Frank elevated his legs every evening for 2 years. And what Frank was never told is that this swelling was not just cosmetic, and understanding why it happens changes how seriously you take it, because amlodipine relaxes the arteries, the vessels that carry blood away from the heart, but it does not relax the veins at the same rate. And veins are responsible for carrying blood back. So when outflow is easy but return is sluggish, fluid leaks out of the small capillaries into the surrounding tissue, and that is the swelling. And in a younger person with strong circulation, the body compensates, but in someone older, especially someone with any degree of venous insufficiency, that compensation becomes less reliable over time. And here is what matters most. Swelling changes how you move. It makes shoes uncomfortable, it slows your pace, it discourages walking, and reduced movement creates its own circulatory problems. A slow, quiet feedback loop that builds without anyone noticing. And if your ankles have been swollen and you have been told it is harmless, ask one specific follow-up. Is there a different medication class or a lower dose that might not cause this? Because in most cases, there is, and never let it is common be the end of the conversation when a side effect is changing the way you live. Number 3 is about a cough that no one connects to the pill on the nightstand, and Barbara Okafor is 72, a retired hospital administrator from Atlanta, and 3 months after starting Lisinopril, she developed a dry, nagging cough. It was not a cold, it was not seasonal allergies. It was a tickle in the back of her throat that gradually turned into a cough that followed her everywhere, through the grocery store, through church, through every meal, and she saw her primary care doctor, she saw a pulmonologist, she had a chest x-ray, she spent 8 months worried, exhausted, and embarrassed before a new pharmacist reviewing her records asked one simple question. How long have you been on Lisinopril? And the answer was 8 months and 1 week. And this is not rare because ACE inhibitor-induced cough is one of the most commonly under-recognized medication side effects in older adults. And here is the simple explanation for why it happens. Lisinopril blocks an enzyme that does 2 jobs. Job 1 is to limit the hormone that tightens blood vessels, and job 2 is to break down a compound in the lungs called bradykinin. And when lisinopril does job 1, it also interferes with job 2. So bradykinin builds up in the airways. It irritates them, and the result is a dry, persistent, non-productive cough that no cough drop, no allergy medicine, and no amount of throat clearing will touch. And in older adults, this cough is more than a nuisance because it disrupts sleep. It causes dizziness and lightheadedness during coughing fits. It can increase fall risk, and it quietly erodes quality of life in ways that are hard to measure. So if you developed a new dry cough after starting lisinopril, mention it to your doctor specifically and ask whether switching to an ARB like Losartan might be appropriate, because for most people, the cough disappears within a few weeks of making that switch. And this is a well-understood, completely manageable problem that you should never be told to simply live with. Number 4 is about the potassium problem, silent, invisible, and serious. And I'm not going to open this one with a single patient story because the data here tells a bigger story than any one person can. And both Losartan and Lisinopril, and in fact the entire class of ARBs and ACE inhibitors, share a well-documented effect that does not get nearly enough attention during routine checkups, which is that they raise potassium levels in the blood. And here is the mechanism as simply as I can explain it. These medications reduce the activity of a hormone called aldosterone, and aldosterone's job is to signal the kidneys to flush out excess potassium. So less aldosterone means less potassium leaves the body, and potassium begins to accumulate and now layer on the realities of aging. Kidney function naturally declines with age, so less potassium is being cleared on its own. And many foods promoted as heart healthy, bananas, avocados, spinach, sweet potatoes, beans, lentils are among the highest potassium foods you can eat. And many older adults also use potassium-based salt substitutes without realizing they are adding to an already rising number. And some people take potassium supplements on top of all of that, completely unaware that their medication is already keeping potassium elevated. And here is the part that worries me most. High potassium, called hyperkalemia, often has absolutely no symptoms, no warning, no way to feel it coming. until it reaches a level where it begins to affect the heart's electrical system. And at that point, it can trigger a dangerous, irregular heart rhythm with no advance notice whatsoever. And this is entirely preventable with a simple blood test. So if you are on Losartan, Lisinopril, or any medication in those classes, ask your doctor today when your potassium levels and kidney function were last checked. And if no one can give you a clear answer, or if it has been more than 6 months, that is a gap that needs to close right away, because it is just a lab test, but it could be one of the most important things you do this year. Number 5 is about magnesium, the deficiency hiding behind your fatigue. And Ruth Simmons is 68, a retired librarian from Raleigh, North Carolina, who had been on Amlodipine for 3 years and for most of that time had been exhausted, not just a little tired, but bone tired. Sleeping 9 hours and waking up feeling like she had not slept at all, and her doctor checked her thyroid. Normal, checked her blood count, normal, and told her it was probably age, and what nobody checked was her magnesium level. And here is something that most patients, and honestly many clinicians, do not fully appreciate. Blood pressure medications, particularly when combined with certain other antihypertensive therapies, can affect how efficiently the body retains magnesium, and magnesium depletion in older adults is already extremely common, partly because dietary intake tends to decline with age, and partly because the kidneys become less efficient at holding on to it. And when magnesium drops, you feel it, fatigue that does not improve with sleep, muscle cramps especially at night, difficulty concentrating, mild anxiety, disrupted sleep, and none of these symptoms wave a flag that says this is a mineral deficiency. They all just feel like getting older. So ask your doctor to include a magnesium check in your next routine labs because it is inexpensive, it is simple, and if your levels are low, replenishing magnesium through food or a gentle supplement can make a noticeable difference, often within weeks. And foods naturally rich in magnesium include dark leafy greens, pumpkin seeds, almonds, and black beans. And if your doctor recommends a supplement, magnesium glycinate is one of the gentler forms and tends to be well tolerated by most people. Now, I want to pause here for a second because we are roughly halfway through the list, and I just want to say that if you have been sitting there thinking I have had some of these symptoms and nobody ever connected them to my medication, you are in extremely good company, because most of us leave doctor's appointments with a prescription and a piece of paper with instructions, and that is the whole conversation, and we do our best with what we are given. So if this has been useful so far, go ahead and tap the like button, because it genuinely helps more people find this information, and it takes considerably less time than sitting in a waiting room. And all right, back to the list, because we are getting into the ones that matter most. Number 6 is about the blood pressure reading that looks perfect but could be putting you on the floor. And Dorothy Callahan is 76, a retired teacher's aide from Scranton, and her blood pressure at every single visit was beautiful, right around 116/70. And her doctor smiled at every appointment and told her the numbers looked great, but Dorothy was falling, twice in the kitchen in 3 months, once on the driveway, and she thought she was just clumsy. She thought maybe her balance was going. She told her daughter she was just getting old. And what was actually happening was this: when her blood pressure was controlled that aggressively, her body was struggling to adapt to the simple act of standing up, because when you go from sitting or lying down to standing, your heart needs to immediately push more blood upward to keep your brain supplied. And in a healthy younger person, that adjustment happens almost instantly. But in an older person on an aggressive blood pressure medication, that adjustment can lag. Blood pools in the legs, pressure drops, the brain gets less blood than it needs for a few seconds, the room spins, you reach for something, you miss, and that is called orthostatic hypotension, and it is far more common in older adults on antihypertensive medication than most patients are ever told. And there is also a growing body of clinical thinking suggesting that very aggressive blood pressure targets, pushing systolic readings below 120, may not be the right goal for every adult over 75, particularly those with multiple health conditions or a history of falls. So here is what to ask at your next appointment. Can you check my blood pressure while I am standing, not just while I am sitting? And that single test, measuring blood pressure immediately after you stand, can reveal something a seated reading will never show you. So request it at every visit going forward, and have an honest conversation about whether your current target is the right one for your age and your health today. Because sometimes 138 is genuinely safer Then 116. Number 7 is about your medication and your kidneys, a relationship that needs watching, and George Whitfield is 73, a retired mail carrier from Memphis who had been on Losartan for 4 years with no issues. His blood pressure was well controlled, his doctor was happy, and at a routine visit, his new nurse practitioner noticed something in his chart that had never been flagged. His kidney function had been gradually declining for 18 months, not dramatically, just quietly, steadily drifting in the wrong direction, and nobody had connected it to his medication. And here is why this matters. Both ACE inhibitors, like Lisinopril, and ARBs, like Losartan, work by interfering with the hormonal pathway that regulates blood pressure, and this same pathway also plays a critical role in regulating blood flow to the kidneys. And in most people, these medications actually protect the kidneys over the long term. But in certain situations, particularly when someone becomes even mildly dehydrated, or when kidney function is already reduced, or when certain other medications are on board, they can reduce blood flow to the kidneys more than intended. And this is sometimes called sick day risk, meaning when you have a stomach bug, a fever, diarrhea, or anything that leaves you dehydrated for more than a day, your kidneys become more vulnerable while you are on these medications. And some clinicians now provide what are called sick day rules, temporary guidance on whether to pause certain medications during acute illness. So ask your doctor 2 things. First, are my kidney function tests being monitored regularly while I am on this medication? And second, are there situations like when I am sick and not drinking enough fluids where I should temporarily adjust or pause this medication? And if so, what exactly should I do? And having that conversation before a situation arises is much better than figuring it out when you are already unwell. Number 8 is about the interaction hiding in your medicine cabinet. And Sandra Bloom is 69, a retired accountant from Phoenix, who had managed her blood pressure well for years on Lisinopril. And then she developed arthritis in her knees and started taking ibuprofen regularly, just over the counter, nothing her doctor prescribed. And within a few months, her blood pressure readings started climbing, and her doctor increased her Lisinopril dose. And the readings still were not great, and nobody asked Sandra what else she was taking, and the culprit was the ibuprofen. And here's the simple version of why. Non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen and naproxen, cause the kidneys to retain sodium and water, which raises blood pressure, and at the same time they reduce the effectiveness of blood pressure medications, particularly ACE inhibitors and ARBs. So the 2 drugs are essentially working against each other, and the medication dose keeps going up to compensate for something that could be resolved by addressing the interaction directly. And NSAIDs are just the beginning, because some common decongestants can raise blood pressure meaningfully. Certain antidepressants interact with blood pressure medications. Some supplements, including licorice root, which appears in more products than most people realize, can raise blood pressure significantly, and even grapefruit in regular amounts can interfere with how your body processes amlodipine. So at your next appointment, bring a complete list of everything you take, not just prescriptions, but everything. Over-the-counter medications, vitamins, supplements, herbal teas, protein powders, and ask, is anything on this list working against my blood pressure medication? Number 9 is about blood pressure at the doctor's office versus blood pressure at home, and why they are not always the same number. And Harold Jensen is 71, a retired engineer from Minneapolis, whose blood pressure at every doctor's visit was elevated, consistently 148 to 155 over 90, and his medication had been increased twice, and he was still not hitting his target. And then his new cardiologist asked him to bring in 2 weeks of home readings, and Harold's home readings averaged 124 over 76, and he had what is called white coat hypertension, a well-documented phenomenon where the stress and anticipation of a clinical setting causes blood pressure to rise temporarily, producing readings that are significantly higher than what a person experiences in their normal daily life. And the opposite also happens, because some people have blood pressure that reads perfectly normal in the office, but spikes during stress, exertion, or at certain times of day. And this is called masked hypertension. And both situations lead to the same problem. Treatment decisions being made based on a number that does not accurately reflect reality, and home blood pressure monitoring done correctly and consistently gives a much richer picture. So here is the simple way to do it right. Sit quietly for 5 minutes before you take a reading. Take 2 readings in a row, 1 minute apart. Log both. Do it at the same time each morning and again in the evening. And after 2 weeks, you have a real data set, not a single snapshot taken under fluorescent lights with a stranger watching. And bring that log to your next appointment and ask, does this change anything about how we are managing my medication? Number 10 is about the mental fog nobody names. And Patricia Dunn is 74, a retired high school English teacher from Eugene, Oregon, who had always been sharp, crossword puzzles, book clubs. She read 2 novels a month, and then gradually things started to slip. She would lose her train of thought mid-sentence. She started struggling to find words she had always known. Her daughter gently raised the possibility of early cognitive decline, and Patricia was frightened. And what had changed in her life 18 months earlier was that her blood pressure medication had been increased. And the connection between antihypertensive medications and cognitive side effects is an area where the science is still evolving, but there is a well-recognized mechanism worth understanding. The brain depends on precise blood flow, and when blood pressure is lowered, especially if it drops more than a person's brain is accustomed to, cerebral perfusion can be affected, and in older adults whose blood vessels may already be less flexible and whose brains may be more sensitive to changes in flow, this can manifest as difficulty concentrating, slowed thinking, or a general feeling of mental heaviness. And this is not the same as dementia. It is different. And unlike dementia, it can often be improved by addressing the medication. So if you have noticed a change in your mental sharpness that is not explained by sleep, stress, or other factors, and it began or worsened around the time your blood pressure medication was started or adjusted, mention it to your doctor specifically and directly by saying, I noticed a change in my thinking around the time my medication changed. Is there a connection? And that question opens a conversation that most doctors will take seriously. Number 11 is about the medication review that never happens and how to make it happen. And Agnes Fernandez is 77, a retired seamstress from San Antonio who has been on the same blood pressure medication at the same dose for 11 years. And in 11 years, not one doctor has sat down with her and asked, is this still the right medication? Is this still the right dose? Has your body changed in ways that mean this prescription needs updating? And Agnes is the rule, not the exception. And here is something important to understand. A prescription written in 2013 was based on who you were in 2013. Your weight may have changed. Your kidney function has almost certainly changed. You may have added other medications that interact with the original prescription. Your blood pressure goals may have shifted based on updated thinking about what is appropriate for your age. And the way your body processes the medication has likely changed too. And medications should not run on autopilot indefinitely. They should be reviewed regularly. But in most practices, nobody initiates that review unless something goes wrong. The prescription refills. The pharmacy fills it, you take it, and 11 years pass. So here is what you can do about it. At your next appointment or in a dedicated phone call or portal message, ask specifically for a full medication review. Say you want to go through everything you are taking and make sure it is all still the right fit for you today, because some practices have a pharmacist on staff or affiliated who specializes in exactly this, and in others, your primary care doctor can do it. But either way, you have to ask, because in most cases, no one is going to offer it unprompted. Now let me bring this all together with the questions written down and ready to take with you. Question 1, why was this specific medication class chosen for me and not one of the others? Question 2, can you check my blood pressure while I am standing, not just sitting? Question 3, when were my potassium levels and kidney function last checked? Question 4, has my magnesium been checked recently? Question 5, is my current blood pressure target still appropriate for my age and overall health today? Question 6, are any of my other medications, supplements, or foods interacting with this one? Question 7, are there sick day rules I should follow if I become dehydrated or seriously ill? Question 8, would home blood pressure monitoring give us a better picture of how I'm actually doing? Question 9, have you noticed any change in my kidney function since I started this medication? And question 10, when was the last time we did a full review of all my medications together and screenshot that list, write it on a piece of paper, fold it in your wallet, or put it on the refrigerator and bring it to your next appointment? Here is what I want you to carry with you from today. Your blood pressure medication should be helping you live better, not just making a number look better on a chart. And if you are exhausted and nobody can explain it, if you are dizzy when you stand up, if you have a cough nobody can account for, if you feel mentally slower than you used to, if your ankles are swollen and you have just accepted it as part of life, these things are worth talking about because they may not be aging, they may be your medication, and medication can be adjusted, switched, reduced, or reviewed. And you have every right to ask whether what you are taking is still the right fit for the person you are today, not the person you were when the prescription was first written. And I will be honest with you. When I first went down this rabbit hole, my reaction was something like, wait, 11 things and most patients never hear about any of them. And I have since come to understand that doctors are working with limited time and doing their best with it. But that is exactly why walking in with your questions already written down is so valuable, because it makes the conversation faster, easier, and more productive for everyone in the room. So if this gave you something useful today, subscribe, because we do this kind of thing regularly, real practical health information for people in their 50s, 60s, and 70s who want to actually understand what is going on with their own bodies and not just be handed a prescription and sent home. And drop a comment below and tell me what you want us to cover next, whether it is a medication, a symptom, or a health topic you have been wondering about and never gotten a clear answer on, because I read every comment and your question might become the next video. And one last thing before you go. Everything in this video is general health information, not personalized medical advice. And every person's situation is different. Your doctor knows your complete health history in a way a YouTube video never can. So please use what you learned today as a starting point for a better conversation with your own care team, not a substitute for one. Take care of yourself, and I will see you in the next one.